Hello and welcome to this webinar on ACL rehabilitation. I'm Claire Ardern, the Editor-in-Chief of the Journal of Orthopaedic and Sports Physical Therapy. JOSPT has a long and proud history of partnering with international organisations that represent our community. And today I'm pleased that we could join forces with our longtime friends at Sport Physio Swiss to bring you high quality, free content that's going to help you help the patients and athletes that you work with. In today's webinar, we shine a spotlight on what seems like a perennial discussion point in rehabilitation circles, the best and safest way to train the quadriceps after an ACL injury. Top clinician and educator, Dr. Sylvia Supon from University of Washington, St. Louis, and top clinician researcher, Dr. Mario Bazzini from the Schultes Clinic in Zurich, Switzerland, will join us to host this webinar. And I'll let Mario and Sylvia introduce our star panelists.
I'm Sylvia. I'm an associate professor at Washington University in St. Louis, and I do have a personal interest in ACL reconstruction and translating best evidence into practice for our clinicians. And so I'm pleased to have Lynn Snyder-Mackler and Kevin Wilk join us to discuss this, as they are both very well-respected clinicians and researchers in their fields.
I'm Mario Bazzini from Zurich, Switzerland, as Claire has already said. It's really a great pleasure to meet, at least virtually, my very long-time friend Lynn and Kevin, and hopefully this will be an interesting time and debate maybe as well.
I want to thank JOSPT and Claire, as well as Sylvia, and also the Swiss Physical Therapy Association, the Swiss Sports Physical Therapy Association, and Mario Bazzini for inviting us to present. My topic is going to be closed kinetic versus open kinetic chain exercise, fact versus fiction. These are my faculty disclosures, none of which should come into play in this particular presentation. So one of the things I'd like to do during this short presentation before we have a discussion is discuss some of the concepts that have been maybe put out there at courses and some of the myths, if you will, and we'll discuss EMG as well as biomechanical studies done here at ASMI in Birmingham, but also across the country and internationally as well. So many times we talk about what's the best exercise. And when we say what's the best exercise, you know, is it for muscle hypertrophy? Is it for proprioception? Is it for dynamic stabilization of the joint? Is it the safest form of exercise? So there's always this kind of risk benefit, if you will, that we have to keep in the back of our mind as clinicians and educators. And so exercise selection is really very, very important. So what I'd like to present as much as I can is an evidence-based practice approach based on, again, EMG studies as well as motion analysis, but also in vivo data on the ACL. So here's some common myths, and obviously in 7-8 minutes I can't go through the majority of these, but I do want to expand on 3 or 4 of these if I can. So a colleague of mine, Rafael Escamilla, out at Cal State Sacramento, when he worked here in Birmingham, we did a series of studies, quite a few, that I would like to maybe get into some depth with. So the first myth is that closed chain exercise produces less ACL strain than open kinetic chain. So this is some work from the University of Vermont, Bob Johnson and Bruce Benyon. What they basically looked at was active range of motion from 90 to 50 degrees. You see no strain, this red line, this measures actual ACL strain, no strain on the ACL, and actually from about 40 degrees up to 0, strain increases with the greatest amount of strain at about 15 degrees, and it's about 2.5% strain. What about the closed chain doing a squat? So this is all in vivo strain gauge data. Again, from 90 degrees to around 50 degrees, no strain on the ACL. And then from 50 to 0, there is strain on the ACL. The greatest amount of strain, around 15 degrees in knee flexion. Again, about 2.5 to 3% strain. What happens when you add resistance? Well, when you add resistance in the open chain, and they did so with a 45 Newton boot or 10-pound weight at the bottom of the foot, strain goes up proportionally to the amount of resistance applied. So there is more strain, as you can see here, by about 1% with that 10%, with that 10-pound weight. With closed chain, they did it with a resistance band, as you can see here to the right. So they used a sport cord. And with sport cord resistance, strain did not increase. So one of the big conclusions that Dr. Benyon and Dr. Johnson pointed out in American Journal of Sports Medicine is as you add resistance in the open chain, strain goes up to a certain point. We don't know what that is, but we know that strain goes up. This was all done with Hall transducers that were implanted in the anteromedial bundle of the ACL. And this is well documented in the literature. They published numerous articles, and some are really phenomenal papers looking at Stairmaster and bicycling and doing a variety of exercises. This is some work we did here in Birmingham, published several places. We're looking at shear forces, both in the knee flexing phase of exercise and the knee extending phase. The green line is leg extension, and squats and leg presses in yellow and purple. You can see with shear forces, and this is at about 90% of a repetition max on all exercises, you can see actually shear is less in the open kinetic chain at all angles. Myth 2 is I do closed chain because it produces higher or maybe always hamstring quad co-contraction. And that's simply not true. It really depends on the position, the angle, if you will, of the joint, but the exercise you choose. So here's a person doing a simple wall slide. He actually has BFR on his thighs. And as he goes down to this deeper angle, even at the higher angles, it's a quad dominant exercise. There is no co-contraction at any point in the range. Whereas if you compare this with a vertical squat, there is co-contraction. And there is co-contraction usually somewhere between 0 and 40 degrees on the way down, and anywhere from 50 degrees to all the way up on the ascending phase. Why is that? Well, you look at the hip flexion angle. As hip flexion angle increases and more mass is anterior, that produces glutes and hamstring EMG. So here's some work that we published, American Journal of Sports Medicine again, looking at squats. On the way down, first 30 degrees, co-contraction. The deeper angles, quads go up, hamstrings stay the same. On the way up though, once you hit 100 degrees of flexion in the squat, from 65 with our subjects all the way up to 0, there was big hamstring contractions and co-contraction, if you will. And some of that is due to the amount of weight they were lifting, as you can see here to the far right, but also that deeper hip flexion angle. So this is a little video from that study we did back in the mid-90s, late 90s. And EMG, I know it's a little hard to see, but it gives you a real-life representation of what's going on the screen. And this will be on the way up, the concentric phase. And you can see hamstrings should be a little bit more than it was on the descent or the eccentric phase. What about leg press? Well, body mass posterior to the knee joint. And look at what happens with the quads as they go into a deeper flex position. Hamstrings stay the same. So there is no co-contraction on the leg press. And again, in the interest of time, I won't show that, but the same is true with wall slides. Wall slides are a quad dominant exercise, but it does matter where your feet are. It does matter how close you are to the wall. And we believe firmly that it will also affect strain on the ACL. That has not been documented yet, but it changes the slope of the tibia, which is really an important concept when we talk about exercise, is tibial slope. Last one we'll discuss is you got to consider where your body is in space. So all these exercises, you say, I'm going to do a squat to produce a co-contraction. That may not be true. It may not be true because it depends on where your feet are. So we did some work in this area. This was Raphael's actually his PhD work, where he looked at 15 different foot positions on the leg press and squat. Feet high, feet low, feet wide, feet narrow, and all of it matters. I just want to mention that's clear. All of this matters. So the greatest quads on the leg press and squatting is when your feet were put very narrow. So you had a narrow stance, straight feet. Greater hamstrings were when you were wider, wide stance. And even when your feet were turned out, you got more glutes. So if you're going to squat heavy weights, you want your feet wide and turned out. Same thing applies at the wall, and that's been well documented with several articles. It also matters if you use some form of resistance like friction or taking friction away like a stability ball, which maybe we can talk about later. Lunges also matter how far you lunge as far as the EMG. So my point is, kind of summarizing it, all matters. And this is well documented in the literature. We've published this several places, as I mentioned. So last couple points, single leg squat. You look at these two examples, this person is at about a 45-degree angle where this person is at about a 20, 30-degree angle. The one on the left, the young lady, will have more glutes, more hamstrings than the gentleman on the right. The one on the right should have more quad EMG. And as I mentioned, we published this in several places in different formats of exercise, JOSPT. We published about 3 or 4 times as far as these exercise concepts. I don't have time to get into knees over toes, but maybe we can discuss that a little bit. So in summary, when you're making recommendations of exercises, it needs to be individualized to a specific patient, but also to the time of the recovery and what their problem is, in this case, an ACL. All the exercise, how they're performed, matters greatly. And it also depends on the pathology, associated as well as primary. What's the best exercise? Depends on the goals of the patient and also the risk, also their joint integrity. So with that, I'd like to conclude, and thank you very much for your kind attention.
So I'm going to follow up here and talk a little bit more about open chain and closed chain exercises after ACL reconstruction. Kevin did a great job on the myth busting, but I'm going to try and underscore that a little bit, and then I'm really interested in the discussion. But this is this idea that open kinetic chain exercise is dangerous after ACL reconstruction is a myth with incredible staying power, and so it is really important that we talk about it. So early after ACL reconstruction, these are the things we're all aiming for, right? Inflammation control, full active knee extension, quad strengthening, and gait training. Obviously, patellar mobilization, as you can see there on the right-hand side. One of our mainstays is, and it is in open chain, either with resistance, with the knee flexed, adding resistance and a dynamometer, or with the knee straight out on the table is electrical stimulation. I know this is a place where Kevin and I agree. I think we talked about this last week. 100% of our patients get NMES after ACL reconstruction. The evidence is really good. It's an incredible way to wake up the quads, and it is, the evidence is very strong for this. So again, day one, we're going to be doing this with our patients. And we're going to be using all the different, all the different kinds of quad strengthening, open chain, closed chain, where we are going to be balancing this with inflammation control. So the first couple of days, we're not going to be doing a whole lot of heavy weight bearing exercise, because that tends to help. You tend to hold effusions, or the effusions tend to get a little bit larger. So in that first week, and then certainly if they have any other kind of concomitant pathology like a meniscus repair or condyle repair, we're going to be really concentrating on that effusion, because the effusion's a bad thing to have in the knee, a persistent effusion. So this is the same data that Kevin showed. This is a summary table from a summary article that the Bainan and Fleming did in 2005 on open and closed chain exercises. And this is the same exact things that Kevin showed. And here you can see peak strain with this 30 Newton meters of extension torque of 4.4 for isometric quad, squatting with a sport cord, for active flexion and extension with this 45 Newton weight boot, 10 pounds. Lockman test is right under that. And just squatting, closed chain, they're all right in that 3 to 4.5% strain, okay? And you got to remember that these grafts are tendons that are replacing ligament, and that collagen tissue responds to tension. That's how it heals. So the absence of strain, it's like immobilization is bad, too much strain is bad. What's optimal loading? They have to be loaded. And in the case of the graft sites, quad tendon and bone, patellar tendon, bone, you have an induced tendonitis that also has to heal. So we have to be presenting strain to those tissues in order for them to heal. So no strain is bad, too much strain is bad. So let's look at some of the more recent data. These are data from Lou DeFreit's lab at Duke. And this is looking at in vivo measurement of ACL length and strain during walking. So if you go back to what we just said, 4.5% strain, look at the relative ACL strains near terminal extension, 13% here, and at heel strike, just before heel strike, right? 10%, 13%, every step, okay? 3 to 4 times that of squatting with a weight or open chain knee extension with a weight. And this is a more, this was earlier, this was in 2012, so this is not new data. We're still talking same exact lab with some slightly different methodology, but basically 12 plus or minus 5% strain for every step. So if you let your patients walk, you should let them do open chain knee extension. So here we have open chain knee extension with resistance, 4%, squatting with a sport cord, 4%, mini squat, 3.6%, walking each step, 13 to 14% strain. So just keep that in your head when you're thinking about this and when somebody tells you that open chain knee extension is dangerous. And so why should we care about this? And we should care about this because people are not strengthening the quads. They're not strengthening and they're not measuring, which I'm going to get to in a second. And I think Kevin and I both have the same sort of bugaboo about this. Do whatever you want, but you better measure. These are data from Matt Ifburn's work. And what they did was they took kids that had been cleared to return to sport, came into their lab, and they did this return to sport testing on them. So some health professional, generally their physician, had said, okay, you're cleared to go back to sport. And then they measured quad strength, IKDC scores, HOP tests, and they divided them up into their pediatric group, adolescent group, and young adult group. And if you look at this, you can see that in terms of their thigh muscle strength, quad strength over 90, which is what we're looking for, a little bit under 70% of the pediatric group met it, 46% of the adolescent group, and 40% of the young adult group. Okay, that's all. When they were cleared to return to sport. And what that tells me is they weren't that the clinicians weren't measuring. Go down to HOP test performance, which anybody can do. You don't need a dynamometer to do that. And again, 40% of this young adult group passed, 40, 60. And then when you get to all criteria cutoff, how many of them passed 90% in all of these criteria? Thigh muscle strength, HOP tests, and self-reported knee function. In the young adult group, it was 0. And the best was 31%. So that tells me that not in these best clinics, not in these top of the line clinics, but when you get out there in the real world, people are not measuring. And I had a student last week who's out on her rotation email me and said, Dr. Snyder-Mackler, where can I get a cheap handheld dynamometer? They don't measure quad strength here, and I want to measure quad strength on my total knee and ACL patients. And I said, well, what do you have to do exercises with? And she said, TheraBand and 2 10-pound cuff weights. And I'm thinking, why are, patients shouldn't even be going there for rehab after these problems. So measure. You got to measure quad strength. And if you don't have an isokinetic dynamometer, use a 1RM on a knee extension machine. That's your sort of best next approximation. And if you use a handheld dynamometer or leg press, they both overestimate the involved quad strength. So then you want your QI to be even higher because you are, as I said, overestimating the involved knees strength. So, but you got to measure. And if you don't have the ability to measure, there should be somebody regionally in your nearby who can do it. I mean, every gym has a knee extension machine. At the worst case, you can send them there, your patients there. This is this is Kevin Sventar place. This is a typical burst superimposition test. This is one of and this is our clinician with the very best voice to scream, kick, 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 kick. So Greg is screaming, pointing at the screen and telling her, kick out there. This is isometric. And we have electrical stimulation on top. And at the peak of the contraction, we superimpose a supramaximal, very brief 10 millisecond bursts of stimulation to see if there's inhibition also going on here. And this is just an idea of pre-op, post-op, 4 weeks, 12 weeks, 52 weeks. Still some, but much less inhibition than earlier on in this. Okay, but we want them giving their all, and we're going to do this as early as 4 weeks post-op. We're not afraid to measure quad strength. And this is just an idea of when you follow a progressive rehabilitation program, and this is in our ACL sports cohort that we just published last year. This is 2 years, quad index, hop indices, and patient self-reports. They're doing great. And Mark's activity scale, almost all of these patients got back to sport. All of them got back to sports, almost all of their index sport. The max score on a Mark's is 16. So they're at about 14, which is a really high activity rate. And these are, high school and college athletes, not pros, right? So with what I would consider to be progressive rehabilitation, where we're measuring. And that's it. Thank you very much.
Lynn, that was a great presentation. I thoroughly enjoyed it. Some great data as well. I think, 2 key points I picked up from that. One was this issue of strengthening by clinicians. And I think one of the trends that a lot of us have kind of incorporated is more functional exercises and less isolated. I myself, I like to do some isolated with functional. And by doing so, I think we can target these muscle groups that people are weak in. For instance, the quad, as you mentioned, but there's a lot of people who have weak hips, weak external rotators, weak hip abductors. So I think that's a key point for everyone to realize. And the other one was your point of, if you're walking, you're stressing your graft probably more than most exercise we ever do in the clinic. And to take that one step further, when you're descending stairs or descending a ramp, it's probably 2.5 to 3 times higher than level walking. So clinicians need to be aware of that when they're selecting exercises and so forth. You're probably not stressing as much as if you're letting people walk to and from school and up and down stairs. Also for patients, be careful descending stairs rapidly early on in rehab.
Thanks, Kev. I think that where we're falling apart here is that we kind of threw the baby out with the bathwater when there was a lot of sort of negative press for isokinetics or in the 80s and 90s, or 90s and a little bit later. People stop measuring. And I don't know how you know how strong your patients are if you don't measure. So that's, the one thing that I hope people take away from this is not to be afraid of measuring.
Great. So Lynn, Kevin, thank you so much for those presentations. That was a lot of great data, a lot of research articles that we can further delve into. So I think one of the reasons that clinicians historically have been afraid to do the open kinetic chain exercise is that fear of the strain that you're putting on the ACL, which I think you guys gave a lot of good data about. Can you talk a little bit about the concern relative to failure rate? So there's always this concern that you'll have increased failure and laxity if you're doing early open kinetic chain exercise, especially greater than 4 weeks. Original clinical practice guidelines limited range of motion to 90 to 40. So I was curious about your thoughts on not only safety of it from a graft longevity standpoint, but also range of motion, maybe restrictions you do or do not place on your patients when they're performing it, and in what time periods.
So I'm going to just say one thing, and that is, when this loosening or other kinds of data, when this was really the time when surgeons were taking aim at this, their tunnel placement was bad. And the only ways you were going to get full extension back a lot of the times, and back in those days, and Kevin and I were both practicing in the 80s and 90s, was by forcing it, essentially. So the graft was a little bit looser and they got full extension. It had nothing to do with what you're talking about, but that somehow this old wives' tale, which is all it is. So people sold things like anti-shear devices for the isokinetic so that they would put the pad up closer to the knee. They started this limited range of motion stuff. And yes, you have, as Kevin showed, you have less strain from 90 to 40 than you do in both open and closed chain exercise, right? In both. But again, I almost don't want to accept the premise of your question, because you're perpetuating this dogma that open chain exercises puts more strain than closed. So I think we just have to kill that sacred cow and then talk about lots of different ways to approach ACL rehab, but you better make sure you're getting the results by testing. That's really it.
I'd like to just add a couple things just from a practical standpoint. The data is great, and we're involved with a lot of the data ourselves, so obviously we believe in what we did. But from a practical standpoint, immediately post-op, I do knee extensions. So it starts usually day 1 or day 2. So we see our ACLs the next day, and depends on their kind of physical condition, and so much as how do they feel after the anesthesia from the day before and so forth, really determines how much they actually do the next day. But usually by the second day, they are doing some open kinetic chain knee extension, straight leg raises, just to get their quads firing with muscle stim. So day 2, they're on muscle stim. I do 90 to 40s initially. And the reason I do that is really more to be quite direct and as honest as I possibly can, more marketing than anything else. I just don't want a lot of bad phone calls from physicians that aren't really up to speed, so to speak, totally honest. So we do 90 40s. I don't mind if they go all the way or beyond that point. I don't wig out or freak out by it. So I'm not really that conscientious with it. And the reason being is, Lynn made a key point right after surgery, the graft's the strongest it's ever gonna be. So if you are actually gonna go to 0, do it. As long as the graft is put in the right place with good fixation, it's the safest the day after surgery. It's gonna be weaker at 8 weeks. So I worry more about the person pushing heavy weights when they go to the gym, or our number of visits are getting eliminated or reduced, and the person's going to the gym and then they push heavy resistance on the knee extension, because I'm worried about the patellofemoral joint as well. So that's my approach. I'm a little bit more cavalier in the beginning, and then I temper the aggressiveness a little bit later, as far as knee extensions, limited range of motion.
So clinically, when you do use these open kinetic chain exercises, do you see that the patients are achieving their goals or getting to meet their return to sport criteria faster than those that do just closed kinetic chain? Do we have good data supporting that for the clinicians that are doing more of those functional exercises by sticking with only closed kinetic chain exercise?
I could say the data that we have, the head-to-head data, the RCTs, I would say both did not very progressive exercise, all of the RCTs that are out there. So we don't have, none of them show strength gains like the ones that we show typically in our practices. So, but what we do see, and I know Kevin sees this as well as I do, is just tons of patients coming in for consults or tune-ups or whatever that have been elsewhere, and they come in very similar to the IFBRN papers, showing that they've been cleared to return to sports and they have a 60% quad deficit because no one ever measured. So my problems are that that's what we're seeing, and when we look at the registry data, we see the same sort of thing, where the strength data are just not what we would consider okay. Short answer, no, but almost all the data that are out there show that by not doing this and by not measuring, the standard of care has slipped.
Yeah, I would agree with that. And just to add to that, I think what's kind of evolved for me is, in the last 30 years, I've never really done one or the other. I've always done a combination. So I can't really comment too much other than other people's data. But as far as what's changed for me to enhance the quadricep return, I would say once you are able to gain volitional control and you don't have any neuro shutdown or neuroplasticity that's occurring, I think blood flow restriction has helped us accelerate that quad return. And I know both Lynn and I are both talking quite a bit about quad strength. It's all important to me. Your trunk, your hips, your hamstrings. I know Lynn agrees, but the point is most studies have all documented that if you have weak quads, you are not going to do well. You're not going to do well functionally, and your knee is going to hurt. So one of the things that's the take-home message for clinicians is if you don't test and you assume they have strong enough quads and you start running and they have anterior knee pain that's diffuse, it's, in my mind, it's probably due to weak quads, unless until proven otherwise, because I've seen it so many times.
I think those are both excellent points that you guys make. So in reaching back to what you said, Lynn, about clinicians are frequently not overloading patients enough with respect to the quads, whatever activity that they're doing. What recommendations would you make for clinicians? What do they need to do? So other than measuring, which I think you both have pointed out is extremely important to know that your patient is progressing appropriately, what should clinicians be using to guide how much overload they are giving their patients to know it's an appropriate load to achieve those strengthening goals?
Well, I think, again, if you've ever seen any of Kevin's talks or videos, it's progression, progression, progression. So what you need to be doing is, there are two things that we want to not happen: swelling, effusion, and knee pain, joint pain. We don't care. We love it if their muscles are sore, but we don't want we don't want their knees to hurt, whether it's the tibiofemoral joint, the patellofemoral joint. Other than that, you should be progressing them pretty much every treatment. And that's, I think, hard for therapists out in the community to do. It's, they're busy. They have, sometimes lots of patients at the same time. But I think, this progressing strengthening exercises and functional exercises isn't really rocket science, right? I mean, you have to that has to be right there in the front of your head, that every day you should be progressing them. And then, for the most part, for strengthening exercises, it's a formula, right? It's just like everybody learns in exercise physiology or Therax, whatever your class is. I mean, strengthening exercises, just make sure once they can do what you prescribe them, add more weight. I mean, that's pretty much as easy as it gets. And then, again, Kevin can speak to the functional exercises because he does a ton of different ones and is always using his imagination for progression.
Yeah, Sylvia, I agree completely. And I think a couple things for the viewers to realize is, we're not saying just do knee extensions, obviously. Lynn's not saying that. I mean, obviously, big perturbation exercise fan and advocate. But we're also saying incorporate other exercise. And I think that's a key point is you've got to change the stimulus. So if they're doing the same thing every day, mentally and physically, their body is going to sleep. My suggestion to the viewers, the clinicians, would be that, I've done from years ago is I have strength days and I have agility days when people are starting out. And it's basically a list of exercises. So they know what they're going to get each day. And each couple days, I just, with a pen, I change the program. And I change it just as simple as you're doing front step downs on foam versus on the box, or you're doing lateral step downs. We can change squats 12 different ways, right? We can do front squats, we can do back squats, we can do goblet squats, we can do split squats, we can do Bulgarian squats, we can do Romanian squats. So you can change that equation, but it also keeps the patient engaged as well. But I think you do get better muscle return. And the other point I'd like to make is just go backwards a little bit. We're talking about all these exercises, blood flow restriction, but if the muscle's not being activated and turned on early on, we're really always behind. And sometimes it's not the clinician's fault. Sometimes it's just the patient has neuroplasticity. That's a couple nice papers that have been published by Dustin Grooms and JOSPT that I would urge people to take a look at. And I see patients like that. They're trying really hard and they just can't turn it on. And when they can't turn it on, Lynn's published nice papers on this, you got to stim them. Muscle re-ed, biofeedback. You've got to pump that central nervous system with stimulus, dual tasking, and so forth. And I would urge the viewers to check out those neuroplasticity articles, because once you get behind by several weeks, you're always going to be behind, in my opinion.
That's a really good point, Kevin. And also, when we think about as we're in the sort of general scheme of things, we're pushing back return to play for especially for younger people. I've run into another issue with docs kind of saying, well, if we're not going to get them back, they don't need to really come to therapy that early. And I think that's another, if you lose that early ability to get the muscles to fire and also to get that range of motion back and control the effusion, you're just behind the 8 ball for the whole rehab. So, I mean, I like to see almost 2 phases, right? Where you're getting those initial impairments under control, and then basically it's all optimal loading from there on out. Once you win that battle.
Does your progression or your recommendations change depending on whether somebody has had a patellar tendon autograft or a hamstring autograft or an allograft?
Well, the only difference is with me, I mean, the majority of patients I see are patellar tendon grafts. So first off, so I probably see somewhere about 2/3 to 70% patellar tendon grafts. One of the grafts that's becoming a little bit more popular now, a resurgence, is quad tendon for whatever reason. My problem with quad tendon is quads. It's as simple as that. So if you use the quad tendon, usually 2 things happen. Early on, motion is a little bit harder to get, particularly flexion. They're a little bit more uncomfortable. And second is they're more uncomfortable with their quads. So I'm not really crazy about quad grafts. For me, patellar tendon grafts are the most challenging in a way to get back because you worry about that tendon developing tendinitis. But again, as we've talked about, I think if you load it and you do it in a nice progressive sequential fashion, opposed to rest it and then load it, I don't think you see the tendon problems. It's less than 1% here. We very rarely have somebody that complains about patellar tendon pain because they're always loading it in a gradual progressive manner. And we're also restoring patellar mobility, also good quad flexibility, heel to glute flexibility at the appropriate time frame, which I think is critical for a patellar tendon graft. If you don't get your knee flexion back, you run the risk again of having patellar tendon pain, as well as patellar mobility is an issue.
So let's talk about, so allograft and repair, which again is, there's some new, that's on the forefront again. You don't have graft site morbidity at all. And with both of those, we're not talking about getting muscle strength back, but in terms of healing of that tissue, that graft is slower. So it really doesn't affect the early rehabilitation, but it does affect how much strain you're going to put on this later on, right? How fast you're going to put them back to play. So let's get rid of repair and allograft for a minute and talk about hamstring, where the only thing that does is we don't do resisted hamstring exercises for somewhere at least 2 months, because in that, just think about what happens. They strip the tendons, so the neural input to those medial hamstrings still exists, and what they do is contract, and they contract up the leg, and then those tendons have to lizard tail down and reattach at the tibia. You end up, if you really start early with resisted hamstring exercises for those folks, you run the risk of them always having this feeling like a quad pull, which annoys them for years. So just leave it alone. Let that tendon regrow, and then do resisted, get going with the resisted medial hamstring stuff. The other thing is the lateral hamstrings do hypertrophy to take over a little bit. Quad and patellar tendon. So quad tendon, I could talk just a teeny bit about that because again, we're seeing more of that as well. So the quad tendon graft comes out of the rectus. That is where it comes from. I not only see difficulties with pain and motion early on, but also quad lag later. And one of the ways that we're attacking that now is by making sure that we're basically treating that just like we treat the tendinitis part of the bone, patellar tendon bone. And that is making sure that some of the open chain knee exercise happens with the hip in extension. So you're actually stressing the rectus is stretched over two over both joints. And that seems to help a little bit with the problems that we're seeing with quad tendon. But I agree with Kevin, there's, you know, the jury is out for sure on this. And the registry data are not wonderful in terms of its strength. So we're going to pay more attention to both the extensor mechanism is at risk with any intra-articular knee injury, whether it's meniscus, cartilage, you know, or ACL, PCL. So when the graft comes from the extensor mechanism, you've got to pay attention to the graft site as well. And that's, you know, again, we've got a tendon, we've induced a tendonitis. We have to figure out a tendinopathy because it might not even hurt initially. And you've got to help that fill in. That's part of our goal. But luckily, the stuff that we do, progressive exercise does that. So, you know, just expect it at some point to hurt a little, and think about it like you're rehabbing a tendon when it's that anterior knee pain part, and use the pain protocols like Karin Silbernagel and the other folks who do tendinopathy rehab do, and say, you know, absent of pain is not the goal. You work within a pain range for that to get that to fill in. So we really are rehabbing two things at the same time.
Allografts are easier to get muscle return back because they just don't hurt as much. The inherent problem with that is the graft. So I know we're talking about muscle. So many times clinicians will see, boy, their quads and their hamstrings have come back so fast, they can go back to sport earlier. That's really not true. And that needs to be cautioned. And a lot of misperceptions are out there regarding return to sports with allograft because they have a 3 to 4 times higher failure rate, maybe as high as 6, depending on the study. So I would caution people to think just because your muscle's back, you're ready to go. A lot has to do with your graft maturation and incorporation with an allograft. That's really the wild card.
What about the amount of knee swelling, intra-articular swelling during the first week or couple of weeks? Does it influence your choice in terms of exercises or strategies to progress or to improve the situation with the patient?
Yeah, absolutely, Mario. You know, the issue with swelling is distension, and distension causes inhibition. And it seems like it inhibits almost everyone. Yeah, for me, I yield to the swelling because that's a sign to me that something's going on to the joint, either early or even late. So for me, I'm going to kind of temper my aggressiveness, whatever I'm doing, as far as the exercises if the joint is swollen. But it's not going to stop me from doing exercises. It's not going to stop me from stimming their quads and doing just maybe a little bit lower level, in particular, more functional movement type stuff. And I think another modality or exercise that we do that can cause effusion is bicycling. So for me, early on, you know, with 2 weeks, we'll put you on a bike 10 days. But if you have a big effusion to your knee, you're probably going to go a little bit slower with biking as well because of the number of repetitions.
Yeah, I agree with you. We are going to monitor that effusion very carefully, and start out with really aggressive effusion control with aggressive elevation and compressions. And then the stem helps with that because the muscle pumping just by itself helps get rid of that.
And I think for their daily activities, just one more point is I think they need a knee sleeve of some sort, some type of compression sleeve. So instead of just an ACE wrap and maybe a post-op brace, that's an individual, they'll get a particular type of knee sleeve. That's usually a knit sleeve. The other thing I'll do in the clinic, Lynn made a key point with muscle stim. We also, if swelling's a real problem, we're going to obviously ice and compress and elevate, but I'll use high volt stimulation on them as well, trying to create a polarity difference, trying to get some of the fluid away from the knee.
I think there's been a lot of great information that's provided today that will help clear up some of the confusion for clinicians. I think some of the important points that we definitely made was, number one, that closed kinetic chain and open kinetic chain exercises, if done in a progressive manner, monitoring for swelling and pain, can be done safely for all patients. And the important thing is to make sure that it's progressive. and that you measure strength. So I think that was a point that Lynn and Kevin are both very passionate about, is the importance of measuring. And so whether it's being done via the handheld dynamometer, a 1 rep max, in some way you need to measure and then accommodate for potential overestimation. In monitoring for the swelling, just making sure that you respect that, you alternate activities if you need to downgrade an activity or take a break from it and then go back to loading when loading is appropriate. So having more of that quiet need will be important in being able to progress that patient successfully.
If you're not testing, you're guessing.
Thanks to all our panelists. Thanks to Mario and Sylvia for terrific questions and for hosting. Thanks to you for joining us. We hope you've got some concrete information to take to the clinic tomorrow. Please visit jospt.org for more great research on ACL reconstruction, ACL rehabilitation, including our free clinical practice guidelines. Follow us on Twitter, we're at JOSPT, and on Facebook, we're JOSPT Official, where you'll find all of the latest rehabilitation content, all of the latest ACL rehabilitation. Thanks for joining us.